So I'm actually really excited because this is the first time that I'm giving this talk. And from my understanding and speaking with Tammy and team, this is the first time that I think they are delivering information around sleep paralysis and sleep-related hallucinations. If you're a person who's living with narcolepsy, you may have encountered that you experience these symptoms. However, you may have also encountered that it's not that common that someone is proactively asking about, do you want them treated? And may listen with an attentive ear, but maybe not offering solutions that might make a difference for your overall quality of life. For me, as a child neurologist and pediatric sleep medicine specialist, even though I see patients across all ages, I very frequently am struck by children who may have the diagnosis of narcolepsy, but the reason that they're seeing me is because of their fear of going to sleep. And that fear is really represented very commonly by not only these REM dissociative features of sleep paralysis and sleep related hallucinations, but also things like recurrent nightmare disorder that is occurring. And the reason I give that illustration is because these are incredibly or can be incredibly impactful to the lived experience with narcolepsy. But it also is important to know that they're not only isolated to the individuals with narcolepsy. And so it should also expose the idea that we shouldn't stigmatize it as only an idea that is associated with narcolepsy, but broaden it so that we're increasing the awareness and also the attention to therapeutic interventions, including lifestyle, behavioral, and pharmacologic options that may actually be impactful. So, in terms of learning objectives today, some of the things I want to do is explore REM dissociative phenomena as it occurs in the general population, as well as people living with narcolepsy or IH. Examine lifestyle behavioral strategies that may improve the frequency and the severity, and review pharmacologic strategies that may improve frequency and severity. So, the agenda for today is breaking down REM and all of its fragments, make sense of why this may be happening to you, who else might be at risk and why, what can you do today to make a difference for yourself, and how can you partner with your healthcare partner to help. So first, let's break down REM in all its fragments. If we want to break down a specific segment of sleep, we really need to understand the overall things that contribute to sleep-wake control in order to be able to really fully understand all the opportunities that exist to improve the thing that may be causing a burden for you. So it's important to recognize that over time, the number of hours that we need in order to feel restored really vary over time. And the older that we get, the less of sleep that we need. In addition to that, we also see that the pattern of sleep and how it's consolidated changes over time. By the age of 5, daytime napping goes away, and we generally are seeing that consolidation of sleep all occurring during those nighttime hours. This also is important to understand because this can start to introduce some different ways that we may see these symptoms being presented. Recognizing that when you're talking about a person living with narcolepsy, that they may not have this consolidation of sleep. They may have sleep fragmented across the day. We may see a different appearance of what sleep paralysis and sleep-related hallucinations, as well as some of their other REM dissociative features look like. And so as opposed to them only being present in the nighttime hours, we may see them also emerging at other times of day. These frequently can lead to misdiagnoses and also some challenges in their own journey, being sometimes labeled as having a mental health condition as their primary reason versus there being a sleep reason like narcolepsy as the cause. So, when looking at sleep-wake control, it's important to know that there are genetic components that influence both our homeostatic drive and our circadian rhythm, and those influence how we cycle through sleep and wakefulness. There are other external factors that can influence our sleep-wake cycle as well, and these are things that we sometimes can see as contributory for both people living with narcolepsy as well as not living with narcolepsy, as enhancing the likelihood of experiencing things like sleep paralysis and sleep-related hallucinations, as well as other REM dissociative phenomena, and including things like nightmare disorder. When overall looking at your sleep-wake control, what we see is if you were going back to this slide of that, the circadian rhythm and the homeostatic drive that is contributing to sleep-wake cycle, we're seeing that there is this interaction that occurs that is contributing to normal wakefulness and the experience of sleep. One of the things that is a limitation about the way that this two-process representation of sleep-wake control is that if we were to only look at homeostatic drive in a circadian rhythm, we would miss out on the fact that there also is something like orexin that is contributing to our sleep-wake control. And so, although not illustrated here, orexin generally is going to have a kind of a combating that homeostatic drive to keep us awake during the day. And so, for some people who are living with narcolepsy, a deficiency or dysfunction in orexin is going to result in having this fragmentation of sleep wake across the day. And also, because of orexin's role in how we have our sleep experience during the night and how we cycle through sleep, may also see that REM intrusion that occurs in the evening hours also occurring during the day, which you're going to see on a future slide when we look at a hypnogram across the day of what someone living with narcolepsy might look like versus someone who does not live with narcolepsy may look like. Now, what's important is that although we might think in chunks of this is what the day across the day looks like, and we're awake during this period and we're asleep during this period, what is exquisitely important when talking about what is normal cycling through sleep, and then also what does the experience with narcolepsy look like, is an understanding of the different phases of sleep and how they may contribute to symptoms experienced. So this is giving an illustration of what is called a hypnogram, meaning that it's giving you a illustration of what a typical cycling through sleep across the night should look like in someone without any sleep disorder. And so it's giving you the illustration of this is wakefulness, REM sleep, non-REM stage 1 sleep, stage 2 sleep, and then non-REM stage 3 sleep. We used to call it stage 3 and 4, but we found that there really isn't a physiologic difference. And so that got lumped together as non-REM 3 sleep. Non-REM 3 sleep is your deepest stage of sleep. REM sleep has your most similarity to the electrical activity and appearance of wakefulness, but it's an interesting stage of sleep because it's not our deepest stage of sleep, and very frequently people mistake it as that, but it is a stage of sleep where a lot of important factors occur. Number one, it's a period where we do a lot of our emotional processing, but it also is a period of our vivid dreaming. So although we can dream in things like our stage 3 sleep, we typically don't recall it. Our REM sleep is this very vivid dreaming, and it also is a period where we experience something called REM atonia, meaning that we're physically paralyzed. Our body, our muscles can't move. So I'm sure you're already seeing that this is giving you a bit of foreshadowing to the idea of REM dissociative features and the fact that when we're talking about sleep paralysis and sleep-related hallucinations, that it's associated with what's supposed to occur during REM, which is vivid dreaming or this very vivid experience of content that is not necessarily occurring, but may feel like it is, but also REM atonia, where my body is paralyzed, and sleep paralysis. So if we had normal sleep cycling like this, what we would expect if we were to experience something like a sleep-related hallucination or sleep paralysis is that it's going to be more common for it to occur maybe when we're waking up in the morning, that because we're seeing our longest duration of REM sleep, that it's going to be more likely for it to occur as we're waking up. And what we are going to find as we go through the data around sleep paralysis and sleep-related hallucination is that that may not actually be true. And the reason why that may not actually be true is because our sleep cycling, when we're having dysfunctions that are causing us to experience things like sleep paralysis and sleep-related hallucination, typically isn't looking like this. It's having a very different distribution because our brain is pretty smart. It does different changes to our sleep cycling in response to the sleep disorders that we may be experiencing. So, what I'm talking about is if we have a person who, let's say, is still cycling the same, one of the things that we can see as a reason for you having a REM dissociative feature might be wakefulness intruding into your REM sleep. So, what you're seeing in this hypnogram here is that a person is still maintaining that same REM distribution, but perhaps instead of having low REM sleep fragmentation, so there's keeping consolidated, staying in that stage of sleep, they're having a higher level of REM fragmentation. Some things that might contribute to that outside of narcolepsy can include things like obstructive sleep apnea, where REM sleep, because of that same REM atonia that causes sleep paralysis, also contributes to a greater degree of floppiness in our airway, which make us more susceptible to sleep disorder breathing during REM sleep, which it can be a reason as to why a person may experience REM dissociative phenomena. This is important even for people who are living with narcolepsy, because people living with narcolepsy may be higher risk for also experiencing obstructive sleep apnea. So you may be being treated and you hadn't been experiencing sleep paralysis or sleep-related hallucination, but as a part of your journey, it starts to be reintroduced. One of the things to go back to the drawing board on is narcolepsy the only disorder that you're living with? And are there other things that have changed that may be now contributing to a higher degree of REM fragmentation? What else you may also see is that this is giving an illustration of, similar to where I was saying you can have REM fragmentation because of sleep apnea. There also can be a variety of reasons as why someone may see something called a REM rebound, meaning that I had terrible sleep for a while, which really disrupted my ability to naturally go into REM sleep. But now I'm doing something that is fixing that. So whether it's I've had very chronic insufficient sleep, or maybe I had really poor sleep apnea. And now, as in this illustration, I gave you a CPAP for treatment. What you're going to see is I have sleep apnea. I now gave you a CPAP and I rebounded into a greater degree of REM sleep. This is a natural phenomena. Again, our brain is really smart. And so this isn't exclusive to only obstructive sleep apnea. We can see this with other sleep disorders that after having such a chronic experience of either insufficient or poor quality sleep, that when we finally get into the sleep that is actually a better quality, we may find that we're going to spend more time in REM sleep. We also see the same type of thing occur with slow wave sleep as a secondary catch up or rebound phenomena. So, when talking about narcolepsy, this word cloud is giving you an illustration of all the things, and not even probably scratching the surface of all the things, but all the things that we may hear about narcolepsy. And so, with that, we can see these REM dissociative features, and REM sleep is a very prominent component of it because of the fact that we know that it's not just a disorder of sleepiness, but it's a disorder that is really characterized by REM dissociative features. When you're talking about cataplexy, sleep paralysis, sleep related hallucinations, we're talking about the features of having REM atonia or REM vivid dreaming in a combination with wakefulness. So if you were to look at a difference between what does someone's sleep wake look like who does not have narcolepsy, you can see that this illustration is very similar to the hypnogram that I had showed you earlier. However, in a person who's living with narcolepsy, irrespective of hour of day, you're going to see this fragmentation, and you may see that REM is intruding in periods of the day that we typically are not seeing sleep, but also not seeing REM sleep. Typically, a person should take 90 to 120 minutes to go into REM sleep. So when seeing the phenomena of these REM dissociative features, especially with an abrupt onset of sleep, it starts to call into question as to whether or not is this someone just experiencing REM rebound, or can there be a condition like narcolepsy that's present? So it's not an extraordinary thing to say that a person may be showing up to a doctor's office for the complaints of things like sleep paralysis, sleep-related hallucinations. And that should be a part of the call to action to consider narcolepsy as a differential. So what are the sleep-related dissociative states of consciousness that may occur? So there are ones that are physiologic, meaning that when they occur, they're not necessarily considered abnormal. They can be found within the typical population. And these include things like daydreaming, lucid dreaming, as well as false awakenings. Some altered states of consciousness can be hypnosis or being induced, like anesthesia, or by using things like psychedelics. Pathologic dissociative states of consciousness that also are represented by REM-specific dissociation include things like sleep paralysis, sleep-related hallucinations, and even things like REM behavior disorder, where a person is not having REM atonia. They are having that vivid dreaming, but they're actually acting out those dreams. So in terms of sleep paralysis, this is a temporary state where you're awake and conscious, but unable to move or speak. That's that REM atonia. And that typically is occurring as you're falling asleep or waking up. This isn't a new concept. As you can see, this is something that you're seeing an illustration of a combination of this sleep paralysis as well as these sleep-related hallucinations. by an artist by the name of Henry Fuseli. And this is something that is called The Nightmare. And you see it's from 1781. You'll see in future slides that there is another version of this that he had done in 1790s because this particular artwork had drawn so much attention, which again is going to be representative of the fact that it's not an overly uncommon thing for people to experience, even those without narcolepsy. When looking at sleep paralysis, at least one episode occurs in a lifetime in about 7 to 8% of the general population. When looking at specific subsets of populations, like around students who maybe they may be more likely because of insufficient sleep, 28.3, and individuals with psychiatric conditions may be even higher risk, where it's about 30% experiencing sleep paralysis. There doesn't seem to be any clear predisposition based on age, nor does there seem to be um, a convincing type of ethnicity. But one thing that does seem to be more commonly occurring is that in studies that have looked at ethnicity as a contributing factor, that those who are non-white are higher risk or seem to experience it more commonly than those who are white. In terms of gender, there's conflicting data where some data gives a suggestion that women may be more commonly affected than men. However, there does seem to be a higher likelihood of individuals who live in a more rural population being more likely to experience this versus those in an urban population. What's interesting is there is definitely a relationship between the position of sleep and the likelihood of experiencing sleep paralysis, meaning that sleep paralysis is more common to occur in the supine position or when laying on your back versus experiencing it in other positions. So just as a spoiler alert, this is giving you also an introduction that there may be a behavioral strategy of trying to avoid sleeping on your back in order to decrease the experience of sleep paralysis. This may also be true for sleep-related hallucinations. Some things that are risk factors. So these are things that have been evaluated and either found to have a pretty good association or there's either no or inconsistent association. And so this is really interesting because it now starts to also introduce things that may be modifiable and some are non-modifiable. So clearly what someone's IQ is or their genetics aren't necessarily modifiable, but it's important to know. So with that, we do find that alcohol, nicotine, stress and trauma, both current as well as historical contexts, especially history of sexual trauma in childhood, can be associated with sleep paralysis. And there also may be some overlap in experiencing of sleep-related hallucinations. There are genetic or familial tendencies, and there's a clock gene that's called PER2, and there's a specific SNP or variant in PER2 that can increase the likelihood of the experience of sleep paralysis. There are also some other genetics that have been evaluated, and we do see that this can run in families. What's interesting is that there also are chronic pain as well as other medical disorders that increase the likelihood of experiencing things like sleep paralysis. And in regards to lower IQ, although it doesn't necessarily increase the likelihood, it increases the likelihood of the sleep paralysis being associated with the fearful or recurrent fearful sleep paralysis experience. Now, although we see things like alcohol and nicotine being associated with an increased likelihood of sleep paralysis, what is interesting is caffeine has not shown that same association. There plus or minus is an association with weight and being overweight or not. There is plus or minus an association of if someone has paranormal beliefs of it being more likely to occur. And there really hasn't been consistency in identifying that a type of diet may make a difference of whether or not it's more of a US based versus a Western diet. However, in regards to things like dreaming and dream content, there have been some studies that give a suggestion of the types of foods as well as the timing of food, making it more likely for things like nightmare disorder to occur, which also starts to spill into wondering of, although it's not necessarily demonstrating for sleep paralysis, well, is there any association in things like sleep-related hallucinations? There is no association with HLA polymorphism, which is an important call out, knowing that individuals who are living with narcolepsy type 1 are more likely to have HLA DQB1 0602 positivity, but specifically for sleep paralysis alone. In regards to personality type daydreaming or mindfulness, there has been no association demonstrated of that being associated with an increased or decreased risk for sleep paralysis. Now, what also is interesting is that there is this evaluation of looking at body experiences as well as sleep paralysis, and you'll see a lot of overlap. I remember as a fellow being trained under Dr. Michael Thorpe that he would frequently ask if I had asked patients of do they ever have out of body experiences or a feeling as though that they're floating over themselves or feel like they're looking back. And it does, in fact, seem to have a high association with experience of sleep paralysis. And so it is something that can sometimes be a valuable question that I ask my patients. And in fact, one of the things that I have found is that some patients find it as being a pleasant experience or have a very positive insight related to this. What this slide is giving you is just some thoughts around what's some lucid insights as well as realism in regards to environmental bizarreness or sense of reality. And so what you're seeing here in both out-of-body experiences and sleep paralysis, that there is a sense of awareness and that there is very frequently a realistic representation and that it is something that is experienced not long after waking up. Other things to be aware of is that sleep paralysis can be associated with feelings of dissociation as well as emotions. And so this is something to be aware of because this now also starts to introduce the ability to think about how can I navigate the experience with sleep paralysis. Sometimes people are reporting these with a negative emotion and a feeling of fear. And that, as again, a spoiler alert later on when we're talking about strategies that can be utilized to navigating this is really giving yourself the ability to have some self-talk during the daytime around interpreting that experience and how you may be able to respond when you do experience that. And so instead of it being a negative experience, how can I have a calm experience? How can I actually navigate this? And by doing that, you may actually be able to shorten the duration of sleep paralysis and even reduce the likelihood of experiencing it. Now, when talking about sleep-related hallucinations, these tend to be visual, tactile, or auditory sensations that occur with sleep-wake transitions and can, plus or minus, occur with sleep paralysis. Again, this is another illustration from Henry Fuseli, who is giving an illustration that very frequently is put on the internet as ways of people describing what they might feel when they're having sleep paralysis, especially when it's co-occurring with a sleep-related hallucination. Very frequently, it's illustrated by very fearful imagery, sometimes being tied down, feeling even like you have your mouth taped, and having kind of that demon that's sitting on your chest. I commonly share I'm not a person who lives with narcolepsy. However, as a resident, because of my periods of insufficient sleep, I did have several episodes of sleep paralysis. And I remember them with very, very significant fear because they always were associated with a very doomful type of experience, that something was coming to get me. And my husband remembers that the very first time that I experienced that, I remember after he told me about this that I was trying to get out of it. It felt like you're trying to run away, you're trying to leave, but all he saw or heard was me laying there still, but moaning in a very, very scary way that he woke him straight up from sleep. And so for me, that is something that I remember so vividly even to this day, and can very much empathize with people who have an experience of having that recurrently. Now, we generally will talk about sleep-related hallucinations in two forms as hypnagogic. You can remember gognic as going to sleep, and hypnopompic, which is waking up from sleep. There also is another form of sleep-related hallucination that isn't typically associated with narcolepsy. They're called complex nocturnal visual hallucinations. These are more likely to occur in a setting of visual or neurologic disorders and are things that are really kind of an expression of the brain trying to put together kind of connections that maybe are dysfunctional. A famous example of this is that what's called Charles Bonnet syndrome. Although this is a daytime feature, it's people who are pathologically blind. They can't see, but will describe things that they are seeing, and it's not actually occurring. In terms of epidemiology and risk factors, people with narcolepsy are much, much more common to experience sleep-related hallucinations, and the studies demonstrate anywhere between 33 to 80%. In terms of the general population, it is definitely a mixed bag, depending on the study you're looking at, giving a lifetime prevalence of anywhere between 2 to 75%. And those living with mental health diagnoses being higher risk, really very similar to those who are living with narcolepsy, representing about 50 to 80%. It also is demonstrating that it's much more common for people to experience sleep-related hallucinations with going to sleep rather than fall when they're waking up. There does seem to be a U-shaped curve with both younger and older population experiencing sleep-related hallucinations. In regards to medical or mental health diagnoses, conditions like anxiety disorder, PTSD, psychotic disorders, and mood disorders do put you at higher risk. It also should be notable that a lot of these disorders also are going to make you at risk for other REM parasomnias like nightmare disorder. And so it may be a common theme of this REM fragmentation or exaggerated REM. One of the things to note is that medications that can be associated include your psychotropic medications and other REM suppressing medications, and most typically occurring when a person is abruptly discontinuing them or withdrawing from them, that it may be more likely for them to experience these symptoms. Now, in terms of the sleep-related hallucinations, it is important to know that very frequently when we're being taught about these as a sleep fellow, sometimes that might be limited to asking patients about a visual hallucination. And sometimes it's only asking them about form visual hallucinations. Like, do you see things? Do you see people in your room? However, what you're seeing by this slide is that there very clearly can be a broad range of different types of hallucinations. And in fact, they sometimes can be multimodal, having auditory, tactile, and visual hallucinations. So the visual hallucinations can be very formed images, seeing someone standing at the foot of my bed or sitting on top of me, versus poorly formed images or even shadows. The auditory experiences can be things as clear and structured as your name being called, to even more commonly a rushing sound or tapping or doorknob or door opening. And there can be tactile or unusual body experiences, so sometimes it can be the association with sleep paralysis, but other times it can be a feeling of body distortion or numbness and even electrical sensations. When looking at the characteristics of sleep-related hallucinations, it is important to kind of understand that not only can they occur at different times of the night, but there also can be a variation in terms of the content. And so you may see someone with hypnagogic, that this can be a gradual progression from simple to complex multimodal, where with the hypnopompic, it may be more complex, especially occurring right out of a REM period. There may not necessarily be as much negative impact in terms of the terrifying hypnagogic. Those are typically going to be very terrifying just by the name. And with all of them, there typically is a detailed recall of it. And so it can occur with other parasomnias, again, like your sleep paralysis, and is important to know that it's not uncommon for that to be something that can be very disruptive to how you're feeling in regards to your sleep. So, in living with the experience, the most commonly emphasized, and this may also due to biased inquiry about it, is going to be your visual hallucination. So, about 55 to 86% are going to be hypnagogic. It's less common for it to be less common the sleep-related hallucinations to be hypnopompic. And the visual hallucinations, it's interesting because although very frequently we're taught to ask about formed hallucinations, it's actually these poorly formed or even these kaleidoscope kind of phenomena where you may see geometric patterns, shapes, light flashes. Sometimes you'll see written text, as well as formless shapes. You can have more complex phenomena, including human faces or figures, but again, it's more of these ill-defined that may actually be more common. Other sensations which can occur concurrently or even sequentially include auditory, which are about 8 to 35% of the hallucinations. Again, this can be what you think is a radio or phone, doorbell, music, voices. In my practice, it's sometimes patients telling me that they thought their parent or their significant other had called them, and they went and looked, and it was like, no, no one was calling them or everyone was sleeping. And so they just kind of were like, that was weird. Tactile and bodily hallucinations or sensations in about 25 to 50%. And this can be a sense of touch, body bodily distortions, feeling of weightlessness, flying or falling into an abyss. What I'll share is that sometimes this actually gets mistaken as things like restless leg syndrome, because a person will describe to me something like, I see spiders crawling in a room and then I feel like they're crawling all over me. And with restless leg syndrome, that sometimes is a symptom we hear is that a person will describe, I feel like there's creepy crawlies on my leg and I have this need to move them around. You can also potentially have an affective content. So examples including being caught in a fire or being involved in an attack. And obviously, that can be very, very frightening for someone to experience. And you can also potentially have just what you feel like is a presence in a room. So perhaps you're not actually seeing the formed or the ill-formed objects, but you're like, I feel like there's something here with me. And that can very much be a very frightening feeling as well, especially for my young adults who are living by themselves. So, what are some lifestyle and behavioral strategies that potentially can be helpful or be impactful? So, first and foremost, if you've ever heard me speak before, I'm a really big fan, not of sleep diaries, but of symptom diaries, meaning really taking an understanding of what does your day-to-day look like? Understanding what are the factors that are being experienced both in the day and the night that influence the burden of what you're experiencing or the things that you want to change, allow for you to recognize patterns and trends of when you may be experiencing things, not only as a binary I experience or I don't experience, but also as a I experience and the intensity is greater or less. Anytime that we are able to identify the patterns and trends that we're experiencing, we're not only leaning into our emotional intelligence of improving our self awareness, but it's introducing the opportunity to use self management, which is another emotional intelligence skill set, to be able to really take control of our own lives. Many times, people who are living with narcolepsy will share with me that narcolepsy has taken over their lives and that they're just living kind of on autopilot and that narcolepsy is dictating what good looks like. My call to action for you today is that that is no way to live. That is surviving. And my encouragement is achieving a life where you're thriving. And you can only thrive by being able to be aware of what it is that you're experiencing and what are the things that you can exercise control over. And sometimes you may not be able to control the experience, but you can control the response to the experience, which we'll talk about as another strategy that can really be impactful and meaningful to being able to live more robustly. You're going to want to look at things like your diet, exercise, alcohol, or any other types of substances that may be influencing what it is that you're experiencing. Sometimes our peer-reviewed research isn't caught up with what people are experiencing and contributing to the symptoms that they're having. And so by you being able to understand what your lived experience is, it again helps with being able to improve. Just a stop smoking. If you're smoking, that tends to be something that can just be helpful to health and wellness in general. But we did see that people who are smoking are much more likely to experience things like sleep paralysis. If you're a person who tends to have a lot of worries or fears, having that worry earlier in the day and consider partnering with a psychologist to be able to investigate some of these worries as they may relate and pertain to not only to sleep paralysis and the sleep-related hallucinations, but also things that may just be bothering you. When we're taking our worries to bed, we again are going to be doing that emotional processing during our REM sleep, which may make it more likely for your REM sleep to not be the most rewarding experience for you to have. And so, in order to potentially enhance the positivity of the content of your REM sleep, it may be helpful to be able to do some of that processing earlier in the day and with someone who's skilled in being able to help you to interpret what it is that you're having. As I mentioned, leaning into your emotional intelligence or your emotional quotient can be a skill set that's worth building. So, when looking at your emotional intelligence, thinking about two of the facets of self-awareness and self-management, and so starting even with a reframing strategy of what I'm experiencing is not going to truly do any harm. Being able to name what you're experiencing and be able to process it in during your wakefulness will help you to be able to utilize those same skill sets when you're experiencing it in a sleep related state. And understanding that although this feels very scary and threatening, it actually is harmless and not actually a true threat to you. Being able to do this will help you to manage your emotion that is related to the challenge that you're experiencing and be able to actually reduce the duration of the event that you're having by being able to kind of scale that back. Cognitive behavioral therapy has been shown to be a very meaningful exercise to be able to actually change the frequency as well as the severity of this. This is allowing you to control what you can control and allowing you also to develop the skill set to have a more productive rather than destructive response to things that are not necessarily the most helpful. And then muscle relaxation therapy it actually, even though it sounds so counter, actually been shown to help in counteracting the immobilizing effects of sleep paralysis. Now, other sleep factors to think about is going to be considering your bedtime routine and environment. And this includes even things like what your lighting is. So, having continuous exposure to things that are more on that blue light or white light wavelength as opposed to a red light is going to actually increase your likelihood of having more sleep fragmentation, which again is going to increase your likelihood of having a poor quality of sleep and having these REM dissociative experiences. As a person, whether you're living with narcolepsy or not, keeping a regular schedule and aiming for a closer to age appropriate duration is also going to help with reducing the likelihood of that REM rebound phenomenon or even a greater degree of exaggeration of REM sleep. You may also want to consider if this is something that is new or intensifying. Are there other sleep disorders that may be a culprit? We saw both obstructive sleep apnea as well as potentially the treatment of sleep apnea being something that can enhance the likelihood of you experiencing this REM dissociative phenomena. And so, one of the things that's interesting is avoiding sleeping on your back may actually change the likelihood of you experiencing this. So, similar to when I'm treating people who have positional sleep apnea, that I may say, hey, we were taught you can sew some tennis balls into the back of your shirt. It'll stop you from falling asleep on your back. You may be also be able to use things that will be kind of your wedges or other devices that can help from preventing you sleeping on your back. And it may be something that will simply help you to avoid experiencing things like sleep paralysis and maybe even influence the sleep-related hallucinations. So some of you may be asking, well, is there a specific drug that we can reach for that is going to help get rid of these? The sleep-related hallucinations are just too much and they're clearly very disruptive. No drug has a specific FDA indication for sleep paralysis or sleep-related hallucinations. However, there are studies and evidence to show that some of these medications may be beneficial or can potentially even worsen the experience of these. So, in terms of something that is over the counter, things like melatonin may potentially be helpful. Now, with that stated, some of this is borrowing from the fact that we know that this can be helpful in other REM dissociative disorders like REM behavior disorder. However, it is important to know that in some people, it can enhance the amount of REM sleep that they experience. And also, when they first start it, it can experience they can have an intensification. However, that can potentially be something that is helpful. It is important for me to specifically state before using any medication over the counter or not, please make sure you're talking to your doctor about it and making sure that it is appropriate for you and that there's someone who's monitoring and partnering with you. REM suppressing antidepressants, the most robust literature is definitely on the tricyclic antidepressants, as this being something that can be helpful with a variety of REM dissociative features. And this can be very helpful, shown to be very helpful for things like sleep-related hallucinations and sleep paralysis. Other medications that can be helpful include things like duloxetine and venlafaxine, so SNRIs, selective serotonin reuptake inhibitors like escitalopram, I've also included prazosin on here, although there aren't studies specifically for sleep paralysis and sleep-related hallucination. It actually is one of the most effective medications for nightmare disorder, especially in post-traumatic stress disorder related nightmare disorder. It may be something that's helpful. Now, what's interesting is there are medications besides tricyclics and SSRIs, which we also use in narcolepsy, off-label. There are medications that are on label for the treatment of narcolepsy that may actually be helpful with sleep paralysis. So pitolisant sleep paralysis was evaluated in one of the clinical trials with sleep paralysis and demonstrated a greater than 50% reduction with the experience of sleep paralysis. This may be related to histamine's role that is seen in regards to the REM experience that individuals can have. And so, what is interesting and unique, however, is that when other wake promoting agents, such as your more dopaminergic agents like modafinil, these have actually been shown that they may actually enhance the experience of sleep paralysis or sleep related hallucinations. Now, again, it's not a part of the labeling, but something that you may see as a secondary benefit. Similarly, with oxybate medications, you may see again a benefit in regards to the experience of sleep paralysis and sleep related hallucinations. Oxybate medications are ones that you're taking at night and are CNS depressants that can help with the consolidation of sleep, as well as potentially improving your ability to have better experience with sleep paralysis and sleep related hallucinations. Now, with that stated, again, it is not an on label indication, but because of some of the reframing it does with your sleep by enhancing the amount of slow wave sleep you're in, reducing the amount of fragmentation of your sleep and amount of REM sleep, you are going to see some of these secondary benefits. And these are sometimes the things that I discuss with my patients as to why we may want to consider the use of an oxybate medication. Now, the last piece that I want to say is that there may be other things. One of the things that I do know is that there are plenty of people who utilize cannabis and cannabinoid products to enhance their sleep. And with that stated, there is one over 400 different types of cannabinoids, and there is a lot of variation in regards to literature of CBD, CBN, THC. There may be some benefit from the CBN category for sleep. However, with THC specifically, there's data to support that this may actually enhance sleep paralysis and sleep related hallucinations. And so I do just want to share that because I also have patients who utilize cannabinoid products because they find that it helps with anxiety, and sometimes they feel as though that it helps with other sleep related abilities of either being able to fall asleep or stay asleep. And so just want to particularly call that out. So, in conclusion, REM dissociative symptoms are part of the defining characteristics of narcolepsy, but not exclusive to narcolepsy. And so, it really is a call to action for us to be able to destigmatize this. Many times, patients are afraid to share it because they're afraid of being viewed as quote unquote crazy because they're seeing things or feeling things, or they feel like they're paralyzed even though they're not. And this is really for me to publicly say, like, no, you're not crazy. You're sharing your lived experience. And if it's debilitating to you, it's worth discussing and treating. Capturing and characterizing your journey to understand what you are in control of is empowering. That is something that helps me to better partner with my patients by really understanding the journey that they're having. If I falsely apply another person's journey to a different patient, it is never going to achieve the outcomes that they're going after. You want to make sure you're using day and night strategies to improve your experience, such as the ones that we've discussed earlier. And you want to partner with your healthcare partner to identify other lifestyle and behavioral strategies that can potentially help you in reducing the frequency and severity of them. And although there are no medications that have an FDA approval, you may want to consider discussing treatments that may help in bringing benefit. Thank you for your time. And with that, I'll answer any questions that we may have. Let's take a look and see what might be in the chat. Um, So one of the questions is, how would sleep paralysis and sleep-related hallucinations appear on polysomnography? Most typically, if we were to see sleep paralysis or sleep-related hallucinations, we may see that a person who's experiencing sleep paralysis is transitioning from REM to wakefulness. However, we would have to have the awareness, and this would be post hoc, that the person I had a episode of sleep paralysis as I was falling asleep or as I was waking up, and we may see that transition. Sleep-related hallucinations, it's difficult to say how they may necessarily appear on polysomnography, as opposed to the complex hallucinations where you'll see an activation of muscle. We generally are not seeing that there's any type of major change in movement. So again, you may see this kind of REM wakefulness type of dissociation. What are symptoms you look for, sorry, when suspecting narcolepsy, and how do you differentiate between other sleep disorders? How do you distinguish between NT1 and NT2 when cataplexy isn't obvious? So some of the symptoms that I look for patients who have narcolepsy are really not just asking about the pentat symptoms, so excessive daytime sleepiness, sleep-related hallucinations, sleep paralysis, cataplexy, disturbed nocturnal sleep, but also trying to ask questions around what is the what does the overall story tell me? And the reason I say the overall story is because people living with narcolepsy generally will have a description of not only that they're experiencing sleepiness, but there usually is a huge disruption to life and a transition of life from one that they knew previously. In addition, I also look at things like what does the growth curve look like? In children, there can be a rapid waking phenotype. So I see that they were living at the 25th percentile, and all of a sudden there was this huge jump to like the 90th percentile. As well as are there other kind of symptoms that also sometimes live along with people living with narcolepsy? So features of dysautonomia, headache syndromes, obstructive sleep apnea, mood syndromes. And it is really important to really understand the presence of that REM dissociative phenomena. So when I see a very high presence of things that sound like sleep paralysis, sleep-related hallucinations, or maybe not that pentad, nightmare disorder, those make me definitely think about it. In terms of distinguishing between narcolepsy type 1 and type 2 when cataplexy isn't obvious, I'm going to say something that maybe sounds a little bit ridiculous for me to say, is that although it can be important to distinguish between narcolepsy type 1 and type 2, the part that I'm always very cautious with is that sometimes there's the perception of treating narcolepsy type 2 as a more quote unquote benign or less severe condition. And so, for instance, when I'm speaking to my residents or my sleep fellows and talking about the approach to distinguishing and treating, I very frequently am really trying to understand the burden of the overall disease and really trying to treat to that. In regards to distinguishing of like when cataplexy isn't obvious, stand, is there features of a more mild cataplexy feature that maybe they're not recognizing because they're still lumping it with excessive daytime sleepiness? I would say the most common one I encounter is head drop, and recognizing that there's probably about a third of patients who will experience a higher likelihood of cataplexy when they're fighting a sleep attack. Many times people think that the head drop they're experiencing is because of the sleepiness that they're fighting off, but it actually may actually be a cataplexy in the neck. Now, another piece that may or may not be 100% consistent, but I will say we definitely have more studies in narcolepsy type 1 and specifically narcolepsy type 1 with CSF deficiency of orexin, is that there is some suggestion that there may be a higher degree of sleep state instability overnight for a patient. I would say narcolepsy type 1 and type 2, although this is not like the Bible's truth, but there may be, when I'm doing an MSLT, there may be a shorter duration of sleep latency in type 1 versus type 2. However, overall, I would say that those are just some of the approaches that I would consider. Now, let me see. Do you have any thoughts on a possibility that muscle atonia actually can have effects on the cognitive state? For instance, association, which comes in different forms, like during sleep attacks, excessive daytime sleepiness, hypnagogic hallucination, sleep paralysis versus in cataplexy. So, okay, do you have any? I'm trying to just see if I understand the question. So we definitely know that a dissociative state, people who are prone to dissociative states, even without narcolepsy, are more prone to experience things like sleep paralysis. And so I do believe that if there is a higher degree of dissociation, like that a person is more likely to experience dissociative symptoms, that they're going to have a higher burden. I don't know if that answers the question exactly, but if not, please let me know. Um, uh, and then another related question, how come sleep paralysis is not recognized as involving a spectrum range like cataplexy? Where, for instance, sleep inertia, brain fog, again, hitting on muscle tonia, the cognitive element, or sleep drunkenness can last for hours into the day, be a minimal or moderate partial extent. That's a really good question around the idea of can there be a spectrum of it? Because I definitely know that I have patients who will describe sleep paralysis almost as though like they believe that it's cataplexy, and I will share that my instinct is always to be like, well, that's not cataplexy, it's sleep paralysis. But what I do think is actually probably more accurate is that it may actually be a hybrid, that a person may wake and have sleep paralysis, and then they have this fear and this angst around it, and that may actually extend the sleep paralysis or the cataplexy. And so I do think part of what you're getting to is we do a terrible job characterizing anything other than excessive daytime sleepiness. And even cataplexy, we still do a terrible job. The definition of cataplexy that we continue to give is wrong. We know active motor phenomena. It can also be present since at least 2011 when Dr. Plotzy published that in Brain. However, we typically still perpetuate it as a loss of tone that occurs only in response to strong emotion. And again, that's wrong as well. So I think that what you're getting at is very, very appropriate for us to have more patient-directed research that allows for us to understand what the spectrum of this looks like. Because to your point, even if I were to use any of the pharmacology that we had discussed earlier, it may not be a binary, it's there, it's not there. Just as we had talked about the lifestyle behavioral, we may reduce the frequency and the severity. If we don't know that there's a spectrum of frequency and severity, how can we actually say we're doing better or not? So I think that that actually is a really, really great question that I don't think we have good answers on. So thank you. Is there a sample symptom tracker that we can share with those interested in doing it? If not, what are some key items that should be tracked? Symptom, time of day, quality of sleep the night before. So, and this is not a self-endorsement, but I will share because this is something that I tell my patients to do. I've created one. It's on my website, damngoodsleep.com, and it's DAMM, Dr. Morse. And essentially what I try to include in it include kind of the symptoms that are being experienced, the burden related to those symptoms, what was the response to those symptoms, were there any medications that were utilized, and then also what is kind of the sleep profile overnight. And so trying to get at the point of I really try hard not to tell patients this is the thing that you should be recording. So similar if I was telling someone to do a headache diary, because then I miss out on the fact that it may not be the one thing that impacts you experiencing it. So for instance, for me, I'm going to give an example from a headache experience. For me, I'm a person who is subject to migraines. However, it was in residency, I realized like there's times where I had really, really bad migraine. And it wasn't sleep deprivation alone. It was if I were sleep deprived, I ate like a steak, like red meat, and that if I drank a glass of red wine. If those three things occurred, it was guaranteed that my head would be in a toilet and I would have a debilitating migraine. If I did any one of those three things independently, generally didn't have a headache. And if I did, it was very mild. I would never even have taken a Motrin for it. And so without me kind of taking a step back and looking at what my patterns were, I would never have realized that, which then empower me to say, I can avoid eating a steak that night, right? And I can avoid having it with red wine. I'll take a martini instead. No, I'm just kidding. But it becomes important to be able to do that. So I'm hoping that in the near future that I'll have some sort of app or something that will be able to make that easier for people. But at this point, even if you just use your cell phone in your notes section or otherwise, that can be something that's helpful. How do you deal with oversleepiness during the day without stimulant drugs? So, Well, I would say that one option would be using a non-stimulant like pitolisant. Another option would be utilizing strategic napping. Another option would be using oxybate medications at night. I also will sometimes use baclofen as an alternative to oxybates for at nighttime and potentially helping with nocturnal sleep, as well as sometimes seeing some improvements in the daytime. And I'm not quite certain if there are other strategies you're hoping for, but please let me know and I'll be happy to kind of see if there's something more specific that you had a question around. Should a person discontinue other things, THC, blue light exposure, nicotine, before going in for a diagnosis? So before going in, I'm presuming before going in for a diagnosis of narcolepsy, what I would say is that I would strongly recommend discontinuation of use of any cannabis containing products before going in for a diagnosis for PhD MSLT, especially. And the main reason for that is because we do know that cannabis can cause a false positive MSLT. And for most of our labs, we do a urine tox screen before the MSLT because we want to make sure that that's standardized and also know anything that may be influencing it. So that may delay you getting to your diagnosis. In terms of blue light exposure or nicotine, in general, when we're doing the MSLT, we're trying to limit the nicotine exposure during the MSLT because that can be stimulating. So would say that those could be potentially helpful. Um, So someone had said, I have been hesitant to talk about sleep paralysis and sleep-related hallucinations to psychiatrists who are not well informed about narcolepsy. Some have responded as if it was a separate thing from narcolepsy, and I fear being labeled with other mental health conditions. I have had some psychiatrists be very alarmed about my night terrors/sleep hallucinations and fear them trying to label me with schizophrenia or something. In regards to waking hallucinations from napping during the day, do you have any insights to the importance seeking psychiatrists with knowledge in sleep disorders, and how common is it to find psychiatrists with expertise in sleep disorders? This is such a brilliant, brilliant statement and question. And thank you so much for sharing it because it is so, so important. Because number one, people living with narcolepsy can truly have other medical and psychiatric disorders. And so the two can co-occur. But you are correct that the stigma around these hallucinations limit people from discussing them and seeking treatment for them, which result in inadequate care. And I will share with you that one of the things that I'm so excited about is that we are seeing an increase of interest from the field of psychiatry in being able to educate about what this looks like. As a part of being on the board of directors for the Sleep Research Society Foundation, we've created a relationship with Psych Congress. We were there last year to give education around sleep and psychiatry. I can state that there are pharmaceutical companies who are also doing a lot of this education around sleep and psychiatry and things like this. And I've been so, so privileged that people like my close friend, Rakesh Jain, who I met through the Psych Congress, and I'm just so proud every time I see him posting on LinkedIn, is a psychiatrist who's been practicing for very many years, who he had publicly declared on LinkedIn and through social contacts, like, I was a psychiatrist who was ignorant to the importance of sleep and these sleep related features. And I now am making it a purposeful change. So I do think that this is becoming an increase in people, in psychiatrists becoming more and more aware and how relevant it is, not only to being able to make the distinction, but also to make sure that they can treat all of their patients better. And is it important for a person who has narcolepsy to have a psychiatrist, if they need a psychiatrist, to have a psychiatrist with knowledge in sleep disorders? I would say that it's something that I really do think is helpful. However, if they don't have experience or knowledge, for them to have the openness to work with your treating physician for narcolepsy becomes so, so critical. And so if you're able to at least have someone who's willing to learn and engage and be taught by you as well is really important. And so I do appreciate that. Tammy, I know that we're at 3 o'clock. I just want to um, No. Are we good? The last question,
Yeah,
there's
I
one
think
more
you have
question.
one more. Yep,
Yep,
perfect.
perfect. Are people with autism more likely to experience sleep paralysis? I'm going to say that I truthfully can't say in one way or another because I can't say that I have come across literature that specifically evaluated that. However, what I will say is that there is an increased amount of literature that is investigating the relationship between autism spectrum and conditions like narcolepsy. And we are finding that there's a suggestion that that may be more common. And so, therefore, we may find that sleep paralysis may be something that occurs. So, I can't say to you yes or no. But because of the fact that anxiety and some of these other mental health conditions, which we know are much more likely in people living with autism, I would say that my guess would be that it may be more likely to occur.